Ladies and gentlemen, first of all, let me thank Yuval and Simon Fischel for inviting me for this beautiful conference and also being in Paris. It's great. My purpose of this talk is very different from the previous ones, because you have heard from Nathan and Santi and also others that where the technology is already there and what we have in our daily usage. My talk would be about how to implement the technology to our daily practice, and also how to try to convince the authorities about letting us to do the technology. So the issue for me is a little bit different. I'm a clinician, I'm another molecular geneticist, so my talk will be a little bit of clinically oriented. I have some thing to disclose. I'm a founder and owner of my clinic, and also I'm running a research laboratory in the US, and also I'm involved in a genetic laboratory in Helsinki, in the foundation of that. So I have some interest in this field, so I cannot be independent. So as far as we know that we need innovations, and we need to bring new technologies to our field, because without that we couldn't go further. So I think RT needs innovations, because if we would state that the success rate is not as high as it could be. For example, the ICMAR statistics of 2008 says that the pregnancy rate only 20%. The CDC report back to 2009 is 19%. And the latest report from SART data, 2015, is 22.4% in this age group. I'm representing the age group because this is the age group which visits our clinic most of the time. So actually, if we would see that the success rate is not exceptionally high, and I'm not sure if we could be very proud of that. 85% of the embryos which we transfer, they do not implant. 20 to 30% of these implanted embryos are multiple gestations. And the miscarriage rate is very high, 35 to 45%. So actually, the end of the story, the outcome, because of these numbers, are very low. But if we go further, because the outcome is not just making the pregnancy, we do believe, the outcome is having a healthy child for our patients, is also the clinical part. So if you see that there are different perinatal issues going on with IVF as well, so there is a higher rate for preterm delivery, of course, because of the multiple pregnancies. The perinatal mortality, the perinatal death, and the stillbirth are higher. Ectopic pregnancy rate is higher. The OHSS, the hyperstimulation syndrome, occurs more often. We know about the cost of the treatment, which is very hard for most of the cases, most of the patients. Of course, we know about the medical risk, cancer issues, and the psychological burden has to be mentioned. And also we have to mention that we do millions of unnecessary embryo transfers, freezing, thawings, cryostorages, consultations, and many, many others. So we do a lot without having a real purpose behind. Our clinic in Hungary was designed to make a kind of complex treatment for our patients. So we are not doing only IVF. There are several fields and areas which we try to cover, but we have the main interest, of course, is to do IVF with PGD and PGT. This is one of our main aim and interest. But we are very strongly believe in doing reproductive surgery. Some of the speakers has had a question previously that what happens if we transfer a euploid embryo to the fibroid, to the uterus with fibroids or adenomyosis or several other issues. So we really believe that the uterine factor is very important. So this is why reproductive surgery is very important to be implemented in a kind of second generation IVF clinics. Of course, the molecular genetics is very important part. So we believe that the in-house genetic laboratory is very important to be around. And the periconceptual medicine is also a very interesting part of our daily work. So we believe that the whole environmental environment around the patients, the lifestyle habits, nutrition, pollutions, and many other things are playing an important role, not even in the laboratory, but also with our patients. So I think this is the concept for designing our clinic. It's an old graph. It's probably well known by you all. So the efficiency of the human reproduction through IVF is dropping dramatically, and this is the majority of the transfers nowadays in the day 5 on the blastocyst stage. But we know that the proportion leading to delivery is 7% for follicles, 13 for embryos, 21 for day 3, and 42 for blastocysts. The SAR data, which has recently been published, shows that by increasing the age, the success rate is dropping dramatically. And also the miscarriage rate is going up dramatically. It has been shown by several speakers in previously. The reason for that is mostly because of the embryos are aneuploid. This has been shown by ASRM, this graph. You see that the number of normal embryos proven by NGS by age is dropping. So around the 44% ages, there is about 15 to 10% only. So probably, as it was said previously by many speakers, this is the reason. And of course, from Hasselt and Hunt, and also the data was confirmed by Jason Frenessey from the United States. This is the data from 15,000 trophectoderm biopsies, and we see that the aneuploid rate is common, and is it increasing continuously by age. So what is the most important in our process, the egg or a sperm, or even both, or something else as well? So we assumed that the egg contribution of having a healthy live birth, the egg is having about 70 to 80%. This is a hypothesized, and also for sperm, it's only about 10 to 15%, but the sperm plays an important role. This is very important. So the abnormal sperm and the abnormal egg can influence the whole process, and the uterus as an environment plays an important role, but its importance of the process is nearly about 10 to 15%. So as we all know that morphology-based embryo selection is outdated already, so it's not good at all, and this is why the comprehensive chromosome screening methods has been coming up to the picture. These are two very nice, beautiful blastocysts. I think all the embryologists would advise to transfer those, and this turned to be a 21 trisomy, and this is turned to be a 16 trisomy. So these blastocysts would not being delivered. As we know that there are different strategies for doing the biopsies. Previously, we have had the polar body, then we have the day 3 and the day 5, the blastocyst approach. Of course, now we all agreed on that the day 5, the blastocyst biopsies has many benefits. I don't like to go in details. It has been said previously this morning, and this is also have been shown previously. This is the evaluation of biopsy techniques, and today more than 95% of the PGS programs are involved blastocyst biopsies because it's much beneficial than the day 3. And of course, there are different screening strategies. Of course, we know that previously there was the day 3 and day 5, and there was the fish. It was said very well with Dagan this morning. I don't go in details. And the 24 chromosomes comprehensive chromosome screening plays an important role. So today, the day 3 biopsies and the fish isn't outdated at all. It's not used in our daily practice. And this is the Antonio Capabo publication, which says the percentage of monosomies in the light blue bars, trisomies, and the partial aneuploids affecting each chromosome. So this explained to us very clearly that why fish cannot be used anymore, because we need to detect whole chromosome panel, all 22, and the sex chromosomes has to be checked. So without that, we are going to fail to tell if the embryo is viable or non-viable. And then the different comprehensive chromosome screening methods has came to the picture. There are two groups, the whole genome amplification, the PCR, SNP array. In our clinic, and when back to 2003, we were able to implement the array CGH, and then we planned to move to NGS when we had to stop our activities, and there are the qPCR and the targeted next generation sequencing methods. The costs are decreasing continuously, and here you see the different products representing the different methods on chromosome screening methods. So also recently, the WHO has changed the terminology of the whole preimplantation genetic diagnosis. I think it's a very important point because the names made a lot of misleading issues here, because pre-implantation genetic diagnosis and screening shows a little bit difference, but also we believe that the screening is also a diagnosis, because you tell exactly about the chromosome pattern of the embryo. So now we have, I'm sure you all know that the pre-implantation genetic testing for aneuploidy screening, monogenic disorders, for structural chromosomal rearrangements, and HLA. So this is the newer nomenclature. So of course we all know that PGTA has several benefits. I don't go in details because it has been proven beautifully in the morning by several speakers that of course it increases the implantation rate. This is a meta-analysis. Every clinical pregnancy rate, ongoing pregnancy rate, also in the randomized trials, also clinical pregnancy rate and sustained implantation rate, more than 20 weeks of gestation has been proven to be higher in all groups. And also it has a very important role in decreasing the miscarriage. This is a publication also probably known by you all. So this is the expected loss rate in RPL patients. It's about 32 to 33, in total 33%. Loss rate after PGS is about 7%. So there is a huge decrease in the miscarriage rate. Our data in Hungary has shown exactly the international data. We have published this in a PGDIS conference before, and you see here we exactly had the same result in our data set. So the sustained implantation rate was higher with PGDA, the clinical pregnancy was higher, and the miscarriage rate was lower. And of course, it also has been shown by Santi as well before, but I think it's very important clinically is to be able to show that array and the PGS methodology eliminates the negative effect of the maternal age. I think it's very important. So if we have a patient about 39 or around 40 years of age, so why to transfer a non-viable embryo? There will be no pregnancy or no live birth will happen. So you see, if we have a euploid embryo, the pregnancy rate will, the implantation rate will stay the same. And this is completely the same for miscarriages. If we, by the advanced maternal age, the miscarriage rate is increasing, but if we have a euploid embryo to be transferred, then we will have the same implantation and miscarriage rate. Recently, the IFFS has published the surveillance. It's coming from 2016, which represents 74 countries and more than 5,200 centers. And they were asking those centers about their opinion about PGTA and what they think about its status within our daily practice. So PGTA was reported to be permitted by 70% of these respondent countries in this surveillance. So you see that more than 70% of these centers are doing PGTA. If the PGTA was allowed, it was reported to be regulated by guidelines that govern its use only in 43% of the countries. So we see that it has the authorities has made guidelines to cover these activities there. This is very important. The PGTA is considered as an experimental, as a non-experimental medical practice. So it means it's an established practice. More than 50% of the asked clinics not addressed 28%, about 80% of the clinics was not mentioning that PGTA is an experimental procedure. Only 17% of the 5,000 clinics has been positioned or said that PGTA would be an experimental procedure. So we have started to do PGTA within our clinical activities back to 2003 by the indications of ESHRE and by the indication of the Hungarian College of OBGYN. I don't go in details, but of course PGD is different from PGTA. We have aneuploidy screening. The indication for aneuploidy screening was advanced maternal age, repeated implantation failure, recurrent early abortions, and severe male infertility. This is exactly which is in the ESHRE guidelines. So we we started by having the legal situation in Hungary according and ruled by the Hungarian Act from back to 1997. And it declares that an embryo on which research has been conducted must not be transferred to a human body, and reproductive cells that have been used for research must not be used in reproductive procedures. So this is exactly tells us that if we would have run research activities on our embryos, that would be completely illegal. Actually, it would be a criminal act to transfer those embryos in my country. Examinations does not constitute embryo research if it is performed for purposes to determine the suitability of an embryo for replacement or implantation for purposes applying this act. So it's also very important because we have to tell the suitability of the embryo. And this is a very important medical and legal and medical ethical issue, that whether an embryo with non-viable aneuploidy is suitable to transfer. Or, that's another issue, whether with viable aneuploidy is it suitable to transfer. And also it's very important that separation of the cells of an embryo only shall be done to diagnose probable disease of the unborn child and to determine the damage of the embryo. For us it was clear because we believe that Down syndrome is a disease, and the damage of the embryo, to detect the damage of the embryo, belongs to this group. So aneuploidy is also a damage of the chromosomal numbers of that. The Hungarian College of OBGYN, in its guidelines in 2008, says very clearly, indicates the PGD and PGTM, and also the PGS-PG8, which says that it has an advisory guideline for that. It advises to perform, in case of recurrent miscarriage, several unsuccessful IVF treatments, and also in case of advanced maternal age. So even the Hungarian OBGYN college has made its guideline to use PGTA in Hungary. So of course we started because the law has said that it's allowed to do, and the Hungarian College of OBGYNs are advised to do. So we started our program in 2013, and of course after we started as I think the first group in Hungary, because we were the first who started PGTA with microarray and also in-house genetic laboratory there. So there we have had several administrative proceedings against our clinics. And for example, in 2014, the Government Office of the Capital City of Budapest Public Health Administration has made a very detailed examination through our program, and also they checked several patient files. And based on the opinion of the Hungarian Human Reproduction Committee, they stated that it was declared that the clinic carries out its activities aiming the PGD-PGS in accordance with its operating license, legislations, and professional rules. So we were happy because we had got the license approved as well with the authorities that everything is going fine. And then the Medical Research Council, the Hungarian Human Reproduction Committee, which is an advisory board to a Minister of Health and also for the government, it's made another examination to our clinic in 2014. Indications for examination by our company were suitable to the legislation and professional rules, and were assessed after genetic consultancy counseling by clinical geneticists with complaint documentation. The CGH test is now professionally accepted test for aneuploidy. PGS cannot be considered as a screening because it is not performed in all patients, only for medical indications by clinical geneticists through a clinical genetical counseling. So it was very, very important, because even the governor authorities and even the Hungarian Human Reproduction Committee has made in writing the improvement of doing that. But quite uncertainly, in 2015, so nearly 6 months later, we have had again a procedure from these Hungarian authorities, and it's very clearly and very suddenly and unexpectedly stated PGS as an experimental procedure. And because they made this statement completely against with their previous statements 6 months before, the previously mentioned authority has banned PGS with an immediate effect in our country. Because based on the opinion of the Hungarian Human Repression Committee, the National Public Health and Medical Office Service launched the proceeding and prohibited to use PGS PGTA. And as far as I am aware, I think this is the only country in the world where PGS has been banned after the usage, after the allowance of the uses. Of course, our company appealed against the decision to the Health Registration and Training Center and the second instance administrative authority. They upheld the instance of decision of this. So the legal procedure was going on, and then of course, our clinic requested a review of the decision. It was a long process. We have had to work with several lawyers. It wasn't very easy to talk to the authorities as well. And we have tried to communicate to them. We tried to convince to them. For example, we have made international conferences with really top speakers from all over the world. We invited the community members. They didn't participated, unfortunately. We have made press conferences. We have made expert opinion letters to the government. Even the Prime Minister was addressed with these letters to try to convince about the damage what this decision has caused to our country. We have made letters, advices, guidelines, scientific materials, lectures, posters, local and international conferences. And of course, we were participating patient support groups and many others. So we tried to do as much as we can to communicate with the authorities. And for after a few years of really hard work, in 2018, the Budapest Capital Administrative and Labor Court repealed the previous PGS banning decisions of the authorities. So finally, we got the license to do it again, and they obliged them to conduct a whole new procedure, which is restarted again. It's very important to be mentioned that the court did not have a possibility to change the banning of decision, but they're, according to the specialty of the Hungarian laws, the new procedure is going to restart. If you go to the website of the Hungarian Ministry of Health, there is a position paper still available on the Hungarian Human Repression Committee website, which says things like this. There are laboratories who uses aneuploidy screening according to valuable scientific body's opinion. PGS does not improve IVF outcomes. So we're still saying that there is no better outcome. And this is, you can find these statements still on the website. Even there are paradox effects which was communicated. I don't know what paradox effects would mean, but this is what they think. For this reason, ESHRE in its statement does not advise in its routine usage and position as an experimental procedure. The possibility would open for genetically based embryo selection, also stating designer babies, which is unacceptable. We all know that designer babies is a very big issue. It's acceptable or not, that's a different thing. But how can we mix the genetically based embryo selection with designer babies? Because at that time we have been using microarray. So microarray even not able to use that kind of information, which would allow us to make a designer baby selection. And also this position paper states that third-party reproduction is involved in the issue. So there are many things has been mixed up here. And also again, it states again that again, ESHRE position is clear. PGS is experimental and there are no routine use anywhere. So we were very much surprised because we are participating most of the ESHRE events and we read the papers. So we were very much surprised by reading that ESHRE does not recommend the routine use of PGS and declare it is an experimental procedure in 2013. So we didn't know where is this statement coming from. So we have approached the ESHRE and we got the letter from the ESHRE PGT consortia that as far as PGT consortium is aware, there is no statement that says that array-based CGS is an experimental procedure or otherwise. So how an authority can refer ESHRE using their name, using the biggest international society, claiming and saying that somebody has positioned array CGH PGS as an experimental procedure. It's completely not true. Opinion of international professional boards remains unchanged that PGS is experimental or so. So this is still there. But of course, I'd like to mention some of the leading opinion letters. For example, this one, Virtual Academy of Genetics, has been published, and you see the long list of top speakers, scientists all over the world, which has stated that such technology should not be considered experimental, and where possible should be made available for routine practice. So there are several experts in the world which start to say that PGS, PGTA should be considered as non-experimental procedure and should be advised as a routine practice. Or there is another one. This has been published in the British Medical Journal, 2017, with again very nice list of top experts in the world, in the field. So we should also consider the implications of non-implementing PGS. For example, the harm that could be caused to patients who have an adverse outcome, assuming that they could and would have chosen to avoid it had PGS been offered. And I think it's a very important statement again, because this is the first statement which says that if we do not advise PGS, what is the consequences of that, legally, ethically, morally? We all want every patient receiving IVF to be given the highest possible chances of success. Of course, we know that. With an open-minded, pragmatic approach to evidence-based medicine, we can increase success rate further. So I think there are a lot of papers, evidence-based papers, and a lot of guidelines, suggestions in the literature which supports the whole field. So thank you for you all by doing these papers. So let me, in the last part of my talk, let me conclude about the result of banning PGT in Hungary. So we started we were able to do PGS and then PGTA with microarray CGH in our program between 2011 and 2015. Due to the legislative change in 2015, we had to close our program, the PGS program, and we had to close the in-house molecular genetic laboratory, which has been, I think, running very well. And then we had to stop performing PGS procedures. Although the PGS banning decisions was repealed, we do not use it until we don't have a clear picture from the authorities again. So now we are trying to communicate with authorities again. So in this period of the time, we have picked out 210 autologous fresh IVF cycles where advanced maternal age, and the average age was 38 years of age. We have made 3 cohorts. There was the PGTA group where day 3 biopsy was done. At that time, that was the routine usage of that. We were just planning to move to day 5 at that time when we had to close, and only embryos was transferred. Then we have the morphology-based selection group in this period of time, and also we had morphology-based. And you see we were transferring 1.2 embryos in total in the PGS group. We had transferred 1.8 and 1.1, so there was significantly difference between the number of embryos transferred. And this is the result we found. The implantation rate with the PGT group was 43%, 27% significantly lower in the morphologically based group, and 37%. Again, this is back to 2013. So then we had array and day 3 biopsies. So the results is lower than nowadays you see, but still it was very exceptionally high at that time. Again, the clinical pregnancy rate was much higher with the PGTA group, and less, of course, with the morphology-based group. Miscarriage rate we found significantly higher. So with the PGT group, we have said 17%, which is higher than nowadays in the publications. But again, it was day 3 biopsies, and then there was 37% and 40% in the other 2 groups. Ongoing pregnancy rate was not significantly different, but it was lower in the 2 groups. So in total, the indication was mostly advanced maternal age. The repeated implantation failure was 33%, repeated pregnancy loss, and genetic background. We tested in this period about 1,200 embryos, and we have the same results. About 60-70% was aneuploid, and 29% was only euploid. The diagnostic rate was 92%, the average age was 38%. So this is what we have found as well. We have found 33 viable aneuploidies, which was detected by PGTA. It's about 2.6%. So we had diagnosed 4 trisomy 13, 2 Edwards syndrome, 8 Down syndrome, 12 Turner syndrome, and others. I'd like to tell you about the case which was very important for us and which had also a very important effect to our activities. So we had a case who was 31 years of age. We made an IVF cycle by ICSI. It was a high responder patient, so it was a little bit overstimulated, kind of mild hyperstimulation has occurred. But then we have 15 cleaved embryos, 10 embryos was biopsied. We made PGS on day 3 by array. We had found 9 euploid embryos and 4 was transferable available. We have made 1 transfer on day 5. We made it as a fresh cycle. It wasn't a frozen cycle. We made a biopsy on day 3 and we did the transfer on day 5. There was 1 fetal sac and 1 healthy baby delivered. Few years later, actually 2 years later, the patient came back to us and she wanted to have her second cycle. And then she was 33 at that time. We were being more moderate with the stimulation because of the previous high stimulation. So we used another protocol and less medication. So we were able to achieve 14 oocytes, 2 cleaved. We had to make morphology-based selection because we couldn't do PGS at that time because it was not allowed. There were 2 transferable embryos and the patient has chosen to transfer both because there was not choice of choosing whether is it euploid or not. There was a twin pregnancy occurred and with NIPT and later amniocentesis, the one out of the 2 has been diagnosed for having Down syndrome. So later on, actually it was both the parents was lawyers, so they were very much shocked of this result and they decided not to carry on with the pregnancy. So they decided to do a selective reduction. But unfortunately, we don't do it in our clinic. We are not in that level of services. So they moved to a university and other centers, and they had to undergo 3 different clinics, 3 different attempts of doing the selective reduction without success. So 2 times they tried to make the selective reduction without success, and in the 3rd center, in the 3rd attempt, they were able to actually make the abortion for the trisomy 21 cases, and later on 1 healthy child has been born. So during the period of time when we were not able to do PGTA, we have had 7 viable aneuploidies detected by NIPT and invasive methods like amniocentesis. All was aborted by the decision of the patient. There are several publications on which is describing the selective reduction, and the selective feticid, it's not an easy procedure to be done, and it's really shocking also for the family, the society, also for the IVF clinic, and of course for the patient, because we know that the technique is we have to make an injection of kalium chloride into the fetal heart, and I could imagine when you try doing 2 times and you fail to do it. So if you can imagine that this is really a shocking situation. I'm sorry for the patient. And if you make the situation a little bit in a different perspectives, because the dropout rate is very important to be mentioned here, because you see that after a certain cycle number, you do not increase your success rate, but the dropout rate is increasing. So if you cannot achieve a healthy pregnancy after 2-3 IVF attempts, the patient will leave you. Probably they go to another center, or they just give up, or they do something else. They do surrogacy, or they travel abroad doing egg donations. So it's really important what success rate, what is the outcome of our procedures, because if we don't do good enough, if we don't have have a good outcome in total, then we are losing our patients without having a healthy child. So as a conclusion, I'd like to highlight some things. Of course, there are several advantages of using PGT-A. Of course, we would like to transfer only normal and euploid embryos. It increases pregnancy rate. We have evidence for that. It decreases the miscarriage rate. We have very strong evidence for that. Decreased time to pregnancy and also live birth. This is very, very important issue if we have a patient over 40. So we are losing their time, losing their chance as well by taking it longer. Decrease birth from trisomies. I think this is also very important to talk about. Decrease the elective termination process, because most of the IVF clinics are not facing this situation. They are just sending the patients to university clinics to do it, and they don't see exactly what it causes to our patients. It helps to avoid transfer, freezing, storage of aneuploid and non-viable embryos. Allows single embryo transfers regardless maternal age, reduces multiple pregnancy rate, improved perinatal outcome. This is very important, and also the predicted accuracy is quite high. I think it increases safety, decreased psychological burden of the patient, and I truly believe that this is more logical and more ethical, because I really much believe that this is non-ethical to transfer a non-viable aneuploid embryo. And of course, I believe it's becoming more socially acceptable. And if we talk about the patient's right, let me mention that we truly believe that the patient has the right to have an access for the modern and advanced technologies. So how could it be that just a body, without having a real explanation, just banning a procedure and banning the whole country for patients to have an access for this fantastic technology? And of course, we don't talk about this, but it should be a separate lecture about the reproductive freedom and the reproductive right for the patients to be able to choose. In Hungary, the abortion is legal. You can have a choice to have an abortion in your pregnancies if you decide it. How could it be that the prospective parents, the prospective mothers, doesn't have a choice for detecting the embryos before the transfer? So, of course, I think it's very, very important to mention. So, of course, we can raise the question, so why? What is the explanation? What could be the explanation of not using PGT-A? So why? What could be the explanation for clinics, for societies, for groups, for individuals, or even for authorities? The technology is not well improved yet. The answer is no. It's very well improved. We don't have enough evidence. The evidence is not enough? No. I would truly believe that there is plenty of evidence available. Are there higher risk or complications because of using the technology? Definitely it's no. PGT is still experimental procedure. In Hungary, yes, but all over the world is no. So there are several publications about it, not to position as an experimental procedure and advise it as a routine usage. Is it not improving the outcome of the patient? Definitely it improves the outcome of the patient, so the answer is no. So what else could be the reason? PGT implementation would need investment? Definitely yes. You have to pay a lot if you are running a clinic because there are higher costs. You have to train the staff. You have to run a fantastic laboratory. It's a time-consuming. Logistics is higher, so definitely it's more expensive. And maybe we have to touch the issue that does it make less profit for the clinics? Because if you don't do PGT-A, then you have several unnecessary freezings, thawings, transfers, miscarriages, new tests done, endometrium receptivity assays, and many, many other things. So I don't have a data. I'm just hypothesizing this.